Sir, we are live now. With all your permission, I'm starting this session.
Sure.
Good evening, everyone present here. I welcome all the participant doctors on today's session. Let's welcome today's speaker with great honor, Dr. Keshav Murthy CV, sir. Sir has done MBBS, MD in General Medicine, DM in Cardiology, DNB Cardiology, and consultant at Manipal Hospital, Mysore. Today, sir is going to speak on a topic sudden cardiac death. Let me tell you overview of the topic. Up to 80% of all cases of sudden cardiac death are caused by coronary artery disease, making it the most frequent factor. A cardiovascular cause of death happens within an hour after the onset of symptoms is known as sudden cardiac death. The total out of hospital survival rate for sudden cardiac arrest is about 7%. To know more about this topic, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Thank you for the kind invitation and a warm welcome to all the participants who are here for this particular lecture. So today I'll be speaking about sudden cardiac death and how do we prevent it. This is a very important topic because day to day we hear a lot of stories about people dying suddenly while exercising, while at home, while relaxing, in sleep, and in many other situations. And sudden cardiac death is becoming an increasingly important problem, especially because of the high incidence of coronary artery disease in our country. Younger patients are dying suddenly, and when such a death is witnessed by family members and friends, it brings in a great degree of anxiety and fear in the people who see that event, and subsequently they undergo investigations and so on, and then nothing is found, and it requires a lot of reassurance for them to come back into their usual mode of life. The other important thing is, in the media you hear a lot of celebrities and people dying suddenly without any pre-existing disease. Many of them are apparently looking healthy and quite solid in their lifestyle, and there is no substance abuse, there is no apparent risk factor that you can pick up in these celebrities, but they have died suddenly, which again imposes a lot of burden, a mental anxiety burden on the people who witness it and many of their parents. So today we'll try to understand some of the causes of sudden cardiac arrest and what is the meaning, what is the definition, and how we understand this particular disease. It's a very huge topic, and I would warn you that many of the slides contain a lot of material, so we may not go through the entire thing. So I'll speak briefly about the definition of sudden cardiac arrest, how we diagnose it, how do we get started and approach a patient who survives a sudden cardiac arrest, and the role of devices I'll discuss today, because diagnosis is a very extensive topic, where to start and where to end. Even as cardiologists, we are not sure how far to go in an individual patient. So let's start off today's thing with the definition of terms. Sudden cardiac arrest is sudden cessation of normal cardiac activity with hemodynamic collapse. That is the definition of sudden cardiac arrest. Sudden cardiac death, sudden natural death, presumed to be of a cardiac cause that occurs within 1 hour of onset of symptoms in witnessed cases, and within 24 hours of last being seen alive when it is unwitnessed. Sometimes elderly patients, they have died in their sleep and there is no attendant to witness that. Then within 24 hours, if it is a death, it is called as sudden cardiac death. In autopsied cases, it is defined as the natural unexpected death of unknown or cardiac cause. Unexplained death occurring in an individual older than 1 year, sudden unexplained death. So sudden infant death syndrome and sudden arrhythmic death syndrome, SIDS and SADS, also come into this category. Unexplained sudden death occurring in an individual younger than 1 year with negative pathological and toxicological assessment and negative forensic examination of the circumstances of death. And SADS, or sudden arrhythmic death syndrome, unexplained sudden death occurring in an individual older than 1 year with negative pathological and toxicological assessment. Note, synonymous with autopsy negative sudden unexplained death. So then we probably put it as an electrical event, which cannot be defined autopsy-wise. So we call it as an electrical event. Many times it is a presumed definition rather than giving absolute proof, because once the patient is dead, there is very little things that you can do to get at a true diagnosis. Unexplained syncope is transient loss of consciousness due to cerebral hypoperfusion, characterized by rapid onset, short duration, and spontaneous complete recovery. So that is the definition of syncope. Many a times people confuse syncope with sudden cardiac death. People think patient had a cardiac arrest, but patient might have had a simple syncopal episode. Arrhythmic syncope is similar with recovery, but highly suspicious for intermittent bradycardia, rapid supraventricular tachycardia, or ventricular arrhythmias. So just remember the 50% rule. Sudden cardiac death accounts for 50% of all cardiovascular deaths, and sudden cardiac death is the manifestation of coronary artery disease in 50% of cases. Coronary artery disease may first manifest as a sudden cardiac death. Then they get resuscitated, a coronary angiogram is done, we find coronary artery disease and treat it. So what are the causes? In the younger patients, primarily it is electrical diseases, cardiomyopathies, myocarditis, and coronary anomalies. These are the common known cause of sudden cardiac death in the younger individual. When we come to the fourth decade, about 50% of sudden cardiac deaths are due to ACS and coronary artery disease. In India, especially in this subcontinent and this ethnicity, we know that coronary artery disease is extremely common, and about 25% of our patients with acute myocardial infarction are below the age of 40 years, and about 50% of our patients with coronary artery disease with myocardial infarction are below the age of 50 years. So 40 and 50, fourth and fifth decade, we have a lot of patients, especially in our country. In the older population, structural heart disease, coronary artery disease, valvular heart disease, and heart failure take their toll once above the age of 40, 50. But even in the fifth decade, about 50% of sudden deaths are still due to acute coronary syndrome and coronary artery diseases. So what are some of the non-cardiac causes of sudden death? Patient dying suddenly within an hour of onset. Extensive intracranial hemorrhage, patient suddenly becomes unconscious. You may have heard stories of patients who are talking or doing some activity, suddenly fell down unconscious and died. Not everything is due to cardiac. They can be intracranial hemorrhage. Of course, trauma and exsanguinating injuries are very obvious causes. Suffocation, toxins, and some of the chemical poisonings, they also can cause sudden cardiac death, including snake bites, viperidae, and toxic cobra bites can kill a patient within an hour. Massive pneumothorax, massive pulmonary embolism, these are all mechanical causes. Aortic dissection and rupture can quickly exsanguinate the patient into the abdomen, and patients may suddenly die without any obvious external bleeding. So we think patient has died suddenly, but there could be an aortic dissection or a rupture which has caused the death of the patient. So in sudden cardiac arrest, many times we do not know what is the possible trigger. Why the patients who have been healthy for several decades, doing their usual activities, going about their routines, exercising, people going to a gym and returning from a gym, or going to walk, very healthy lifestyle and habits, suddenly they die. And in many of the cases, it is still perplexing for the general public as well as for the cardiologists also sometimes to pinpoint when we are asked to say, what is the possible cause of death in this patient, or how do you prevent such an event from occurring in their friends or family or siblings or parents? How do we prevent that? There is no exact answer for this, though we say, okay, have a cardiac evaluation where there is a high index of suspicion, undergo electrophysiological study, prolonged monitoring for arrhythmias. Despite all this, we are unable to find a cause in many of the cases, so we should confess to that. We always say, okay, coronary plaque might have ruptured, causing an acute myocardial infarction, and ischemia is the trigger in many cases. Of course, unless an autopsy is done, we can never prove this, and we escape into that comforting explanation. However, patients who have fever, who have infections, especially you might have noticed during the recent COVID epidemic, several young patients dying suddenly following COVID, whether it was an arrhythmia, whether it was autonomic imbalance leading to sudden sympathetic discharge and arrhythmias, and various other complications which we have seen, like an increased incidence of myocardial infarctions, strokes, pulmonary embolism, all these got increased in the COVID epidemic, causing sudden cardiac deaths in relatively young individuals. Of course, drug intoxication may be a possible trigger. Alcohol, of course, it has been known very specifically for atrial fibrillation, but it can also cause other cardiac arrhythmias. Stress, emotional stress, social stress, we have seen in the movies and in TV serials where there is a stressful situation and patient clutches and the actor clutches his chest and suddenly falls dead. It may be true for a coronary event like a plaque rupture, which can act quite suddenly, trigger an arrhythmia. If it is a ventricular fibrillation, it is only a few minutes to death. Exercise triggered sudden cardiac deaths are fairly common. We hear of extreme exercising individuals doing in a gymnasium suddenly collapsing. The athletes while playing, football athletes or contact sports athletes during the game having a sudden cardiac death, quite common. And of course, emotional trauma I have mentioned earlier. So this is a very important slide put together by the European Society of Cardiology. If you see, there are various triggers and various arrhythmias. So there could be genetic triggers, there could be exercise-induced triggers, there could be some triggers specific for like Brugada syndrome, swimming may be a trigger, and age, accordingly the different ages, the first decade to the 8th decade, male versus female, the blue being the male and the red under the line, the female. So there is a preponderance for various different types of arrhythmias. If you see and carefully spend some time on this slide, you will understand the wide variety of things that can come up when we investigate a patient for arrhythmia, polymorphic VT or monomorphic VT, what is the type of arrhythmia and which decades the predominant causes occur. Like I mentioned, acute coronary syndrome, 4th decade and 5th decade maximum incidence. Of course, it can occur in the younger population also. These are the extremes of age in the 1st and 2nd decade fall into familial hypercholesterolemia, or they have some kind of coronary anomalies which cause myocardial infarctions in the very young population. Sarcoid hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic right ventricular dysplasia, repair TOF, chronic coronary artery disease fill up the rest of the causes for sudden arrhythmic cardiac deaths. So genetic triggers we should note in these particular condition, LQT, some of the acute coronary syndromes, hypertrophic cardiomyopathy is very well known. Younger age of onset in children, sibling who has died suddenly with hypertrophic cardiomyopathy, which has an autosomal dominant inheritance. All these can have a genetic basis. We have understood and we have studied, and some of the genes have been clearly identified in these particular conditions. So these are all the recommendations. We'll just quickly go through it to how to defibrillate patients when they have a cardiac arrest in the periphery. The commonest cause of death is there is no access to a defibrillator. So many of the countries have mandated that defibrillators should be placed in shopping centers, stadium, public transport stations, casinos, where people suddenly fall dead. And public access defibrillation should be available at sites where cardiac arrest is more likely to occur, wherever there is stress, or in a gym, or in a public place. Even in the airports, you can see defibrillators. Prompt CPR by bystanders definitely saves lives, because when we see patients who arrive without CPR in a hospital compared to patients who have had a CPR, the chances of survival are significantly better in CPR. Where this CPR has been done by bystanders, having a neurologically intact alive patient, bystander CPR is extremely important. So now, of course, technology has moved forward with various kind of monitorings that have been available with wearable devices like watches and mobile phones, where you can directly track the patient's heart rate and get an alarm when there is a particular event. So what are the red flags? When do you kind of think of a sudden cardiac death? When do you think of investigating a patient? Whenever there is a family history of sudden cardiac death, when you talk to cardiac patients or they come with a very anxious face asking for whether I will have a sudden cardiac event. And when you inquire the history, if there is a sudden cardiac death in the family, you become more serious in that investigation. You may go to the extent of doing the cardiac monitoring, telling them to wear a wearable device and look for arrhythmias very seriously. If there is history of epilepsy, which may be a seizure which is occurring due to a cardiac cause mistaken as epilepsy, many of the patients have ventricular tachycardias mistaken as epilepsy because they become hemodynamically unstable and have some kind of arrhythmias. If there is deafness, which is associated with long QT syndrome, history of drowning or accident when patients have a syncope or an arrhythmia during driving, suggestive of long QT syndrome, who has died suddenly, definitely a risk factor. Patient with heart failure, about 50% of the patients have arrhythmic deaths, especially in the better NYHI classes, and 50% of course die due to progressive heart failure. If there is a family history of a pacemaker implantation less than 50 years of age, that indicates a bradyarrhythmia, which may be inherited. So those are the red flags. When you see a red flag, what do? You do a skin examination for erythema nodosum, xanthelasma, for premature coronary artery disease, palmoplantar keratosis, mitral valve clicks, outflow tract murmurs. These are all the clinical examination findings, which will give you an alert to look for more serious conditions in these particular patients. So in a sudden cardiac arrest survivor who has been resuscitated, so this is the flow chart we generally follow: a 12-lead ECG, urgent coronary angiogram. If there is a culprit lesion, further evaluation according to STEMI guidelines and treat them. If there is a STEMI, if there is no STEMI, think of electrical instability, suspicious for ongoing myocardial ischemia, evaluation of the patient echocardiogram, suspicious for extracardiac cause, brain and chest CT, extracardiac cause is identified, then treated as not cardiac. Then you do toxicology, genetic testing, repeat and review the ECG, and pre-excitation could be the cause or a suggestive of primary electrical disease. Look for that, like something like Brugada syndrome. If it can be identified, it can be treated possibly with a prophylactic implantable cardioverter defibrillator. So these are the flow charts. When you find a VT, you do basic echocardiogram, make sure that the heart is structurally normal. Cardiac CT or angiogram, almost always we go for it because that is the gold standard. And first you have to rule out coronary artery disease in any patient with arrhythmias. Late gadolinium enhancement of CMR is a very important marker of patients who are prone to sudden cardiac deaths. So that is how we investigate these patients, sudden cardiac arrest victims, those who are resuscitated, and try to find a cause. And whenever a cause is found, if it is preventive and where prevention definitely helps, we try to go in that particular pathways. So I'll briefly talk about devices for the next 5 minutes about sudden cardiac death and prevention from priors to devices. A few decades ago, whenever there was a sudden cardiac death or a near relative with a survivor with a sudden cardiac arrest, we had only prayers. There was no hope for these patients in the form of devices. Now in the current era, we have several types of devices which definitely have saved lives, which we have seen in clinical trials, up to 38% reduction in mortality, both in primary and secondary prevention. So ICD save lives, about 30% reduction in arrhythmic deaths, very significant mortality reduction across several primary and secondary prevention trials. And the number needed to treat is very low. Treating about 10 patients saves 1 life, which is a very important thing. And it is one of the most underutilized therapy in cardiology because of the lack of awareness that devices do save lives. They are currently very expensive, and in a country where patient pays from his pocket, in our country, about 70% of the patients do pay from their pocket. It is still out of reach of many of the common patients. So common men. So when we tell them about a therapy that saves lives, even though we emphasize that, many of them are not able to afford, so they keep postponing it and suffer from sudden cardiac deaths. So in primary prevention and secondary prevention, how do you choose them? History of myocardial infarction, what is the kind of, whether it is a structural heart disease or structurally normal heart, and we have found something. And symptoms, giddiness, pre-syncope and syncope, what NYHI class they are. For example, if they are NYHI 4 and the survival is unlikely to extend beyond 6 months to 1 year, then there's no point in putting a very expensive device for this patient. To treat their heart failure, treat them with appropriate medication and try to improve their overall condition and keep them healthy. If there is an end-stage malignancy, for example, You don't want to put a ICD. Asymptomatic high-risk patients, first symptom may be a sudden cardiac arrest. So do not ignore these patients, though they are asymptomatic, saying that I've never had a syncope, I've never had an arrhythmia. Why do you want to privately prevent it? Because the first presentation itself may be a sudden cardiac death. That's how we should counsel patients. So some of the basic investigations, the most basic being the ECG can give a diagnosis of long QT syndromes. It can give a suggestion of Brugada, which can be picked up either at rest or during some kind of provocation like fever or giving a drug. Hypertrophy patterns, quite easily diagnosable, prior myocardial infarction, arrhythmogenic right ventricular dysplasia. So these are some of the things which can be very easily picked up from as simple investigation as a ECG. A splintered QRS complex, especially the terminal portion of the QRS, if it is splintered, it alerts you to look for more important causes and monitoring may be indicated. Look at this ECG, a very classical type of Brugada syndrome, an ST elevation in V1, V2, and V3, which is a conduction abnormality, sodium channel abnormality, easily picked up. And if they have an arrhythmia, documented arrhythmia, of course, we have to treat them with an ICD. Single most important factor on echocardiography is LV ejection fraction, and we see the cutoff when the LV ejection fraction is less than 35%. All these patients will benefit from implantable cardiac defibrillator as primary prevention, even though they have not had an arrhythmia so far. Definitely, their risk of sudden cardiac death will be reduced. Now we have cardiac monitoring devices. Of course, Holter has been there for several decades. We now have, it can pick up sustained and non-sustained ventricular tachycardias. Implantable loop recorders are very useful when the arrhythmia is infrequent, and a single recording of Holter for 24 hours or 72 hours or even 1 week may not have picked up. Then if the patient has very typical symptoms of palpitations, syncope, and there is a high degree of suspicion, we can put a implantable loop recorders. Now we have, with the latest technology, wearable devices, several watches which are available for the people from the market itself. They can wear those devices and some trigger alerts can be received regarding a arrhythmia. So cardiac MRI, late gadolinium enhancement is a good indicator of scarring, and more than 5% scarring is a high risk for sudden cardiac death. So which device do you implant for these patients? A single chamber ICD is enough for most of the patients to prevent sudden cardiac death. If patient requires a pacemaker, for example, if patient has a high-grade AV block and requires to be on pacing rhythm, we now most often go for a dual chamber ICD. If there is LV dysfunction, we directly go for a CRTD. If there is a LVPP pattern with LV dysfunction, consider CRTD. And now we are doing more and more of left bundle and his bundle pacing, which are newer advances, which may alleviate the need for a CRTD. So there are several advances, recent advances in the devices. Now almost all devices are MRI compatible. They are intelligent devices which can be programmed to a large extent. Leadless subcutaneous ICDs are now available. The devices are all Bluetooth connected, and real-time monitoring is now possible in the patient's own mobile phone receiving the data. Remote programming is possible. The latest one is a leadless CRTD, where we can pace both the chambers and have a defibrillator effect. Of course, once transcutaneous charging comes, it will revolutionize the field, because you don't need to kind of change the pacemakers or ICDs frequently. This is one device which is a wearable ICD vest, which can be worn like a shirt or a t-shirt and has a defibrillator function. It can pick up the arrhythmias and shock the patient. Whenever a patient, say for example, a post-myocardial infarction patient who has a arrhythmia, low ejection fraction, and you are waiting for the mandatory period of 6 weeks before we can put a ICD. In that period, if patient asks for protection, if patient wants to make sure, you can offer them a wearable vest, which they can wear except while bathing. The rest of the times they can wear the vest. It will detect the arrhythmias and give an appropriate shock. So this is a leadless subcutaneous ICD, where there is a retrosternal small incision, pocket is made and kept there. And this is the ICD. It avoids the complications of putting leads into the cardiac chambers. So this is how a leadless CRTD works. And the most recent advance, and it will be an excellent device once it is available worldwide. So why are the devices underutilized? Though the devices are present and available and save a lot of lives and a lot of positive data is there, only 40% of indicated patients actually receive an ICD, more or less so in our country, especially more less than 10% maybe. Even physicians may not be aware that ICDs save lives in the appropriate patient when they are used in a very appropriate manner. Of course, cost is a very important problem in our country, and availability of skilled physicians who can implant. Thank you all for your attention. I know it is only part of the topic which I was given regarding sudden cardiac death and its prevention, but because of the extensive nature of the topic, I could just give a brief introduction of what sudden cardiac death is and how to prevent them using devices. That's all that I have spoken today. Maybe in another class, we can continue to discuss about various methodologies to detect who are the patients at high risk of sudden cardiac deaths. Thank you all for the attention and being present here. I hope you have taken home some good messages from this.
Thank you so much, sir, for giving your valuable time and sharing your knowledge with us and making this session informative one, sir. I definitely think this session knowledge is going to help all the participants who have joined these sessions. We have received some question from the participant. If you allow, can I take this question with all your permission, sir? Yeah, sir. The first question is, what are the rare causes that one can find in autopsies of sudden cardiac disease, death, sir?
Yeah. These are all the diseases which I mentioned are all not very common diseases, something like Brugada syndrome, arrhythmias, idiopathic ventricular fibrillation. These are all quite rare diseases. The common diseases are the hypertrophic cardiomyopathies, heart failure, dilated cardiomyopathy. These are fairly common. We pick them up from the general population. But the arrhythmic deaths, the idiopathic VFibs, these are all quite rare conditions.
Okay, thank you so much, sir, for answering it really well, sir. Moving forward, I can see a few more questions. And the question is the risk of SCD in proportion to the length of the QTC's interval in children with LQTS with confirmed mutation LQTI1?
Yeah, certainly. Very good question. The length of the QT interval is directly proportional to the incidence of arrhythmias and sudden cardiac death. But sudden cardiac death in LQT patients can also occur without a prolonged QT on the surface ECG. That we have to be careful about, of course. If there is genetic basis and the patient has a confirmed long QT, then it is directly proportional. Yes.
Okay, thank you so much for answering it, sir. I can see some more question. The question is, what screening, genetic or otherwise, should children of an individual who died of sudden cardiac death undergo?
Yeah, this is a very important question. Like I said in the beginning of the lecture, it is very difficult even for a cardiologist or an arrhythmologist or an electrophysiologist to decide which patient to choose and how much deep we should go into investigations. But if you have had a family history of sudden cardiac death, young age of onset of cardiac disease in the family, maybe we should rule out structural heart disease, definitely. And if they are in the third or fourth decade, maybe a coronary angiogram, and prolonged monitoring, especially if the history is suggestive of an arrhythmia, prolonged monitoring device, implantable loop recorder, certainly. And if they have any arrhythmia like NSVT or any high-risk features like a splintered QRS, heart rate variability, which is low, all these would indicate that this patient may benefit from doing an invasive electrophysiological study. Because even in an electrophysiological study, when we do sometimes the arrhythmias may be provoked or the arrhythmia may not appear at all and patient may have a sudden cardiac death. So, but when there is a definite indication, certainly these patients should undergo a EP study and certainly a genetic evaluation. Family history is a very strong predictor for sudden cardiac death patients. So if there is a young sibling death or sudden drowning or post-exercise syncope or death, certainly we should do the genetic screening. We know that there are many diseases and genes which have been associated or group of genes which have been found. But currently there is no therapy. That also we should be aware for the patient. So we find that which will be useful in counseling the patient, that he has a gene-based disease, and it may be transmissibility also we can tell the patient, so that their children, what is the risk of getting the same disease in children, so that patient can decide whether to have children or not. So this, in this way, genetic thing helps, and certainly indicated when you select the patient carefully. But if you see and try to do that in the entire population, then you will be doing a lot of investigations without getting enough results.
Okay, thank you so much, sir, for explaining it really well, sir. I hope that participant who have asked this question has received his answer. So last question I can see for today's session, I will be taking this last question. The question is that, is the risk of sudden health in mitral valve prolapse associated with the degree of confinement MR? If yes, is the risk modified after MV repair?
Yeah. Mitral valve prolapse has been associated with sudden cardiac death. But when you see an overt patients, they are not directly correlatable, the severity of mitral regurgitation. So if they have significant mitral regurgitation, which satisfied the criteria of severe mitral regurgitation with respect to ventricular volumes and dimensions, you treat that mitral regurgitation. It does not alleviate the risk of sudden cardiac death in a patient who is prone for it. So it only treats that mitral valve disease, because it is not a linear correlation in these particular patients.
Okay, sir. Thank you so much for answering all the questions, sir. As I can see, there is no more question from the participant end. As there is no more question, shall we conclude this session with all your permission?
Definitely. Thank you so much. Thank you.
Welcome, sir. Until then, take care of yourself and hope to see you again with different topics in upcoming months, sir. Thank you so much, sir.
Thank you for that.